So, welcome to another episode of Voices in Health and Wellness, where we sit down with healthcare leaders who bring both depth of insight and practical experience to some of industry's most pressing questions. Today's guest is Dr. Charles Pollock, a clinical scientist and educator whose career spans emergency medicine, public health, and medical education. He currently serves as the medical director at academic CME and holds an academic appointment with the University of Mississippi School of Medicine, while also contributing actively to continuing education in clinical practice. So, warm welcome to you, Charles. Well, thank you for joining us and welcome to the show.
My pleasure. Thanks for having me.
So, can you give us a little bit of a snapshot of your current roles and how you balance academic CME with your ongoing academic and clinical work?
Yeah, so it's been a circuitous route. I went to medical school on a U.S. Navy scholarship. And so after medical school and exclusive of training, I had a 4-year obligation to pay back as a naval medical officer. I was fortunate to do that, assigned to the U.S. Marine Corps back in the 80s. It was during the Reagan buildup of the military in the U.S. And so it was a great time to be in military medicine. We had resources that military medical officers often didn't have before then, and certainly don't have now. But that was a maturing experience for me. I went through college earning 3 degrees in 4 years, and didn't have a whole lot of social life, to be frank. So when I was with the Marines in Asia and the Far East, I finally got to have a little bit of a fraternity life, which was fun. And taking care of primarily a group of healthy young men, occasional women, and the occasional family members who were assigned with their active duty relatives. But it gave me an interesting perspective on life and a great respect that we do have people who are willing to storm the beaches on behalf of the rest of us. I finished my time in the military to pay back my medical school scholarship. And whereas I'd left medical school thinking I was destined to be a general surgeon, during that payback time, I decided that maybe that wasn't the life for me, particularly becoming friends with a number of surgeons whose professional life completely consumed their personal life. I know not every surgeon is that way, but it certainly seemed to be a majority of them. And I sort of happened upon emergency medicine, which when I was in medical school was a very young specialty. In fact, an emergency medicine elective wasn't even offered at my medical school in the early 80s. That started about the time I graduated. But of course, I was exposed to the emergency department when I was on other services, going down to see patients who were being admitted to the hospital. And I matched to a general surgery residency at the Naval Hospital in San Diego. The second month I was a resident, I did an elective in the emergency department because the Navy, the military in general, has a sense that their medical officers need to have broad training beyond whatever specialty they have. And I really enjoyed it. And from that point on, I was tilting away from surgery and towards emergency medicine. I actually did my emergency medicine residency as a civilian after my military obligation was completed, and was destined, I felt, for a career in academic emergency medicine. I was older than several or most of my residency colleagues because I'd done this 4 years of military payback between internship and residency. So I had a little broader worldview than perhaps some of my colleagues did. I also had a number of publications that I had done from research that I conducted while I was still on active duty. And so it made me a little unusual in that I had more of an academic presence than my colleagues. To give you a sense, Andrew, of how young, I mean, you remember how young and undeveloped emergency medicine was at that time. My chief resident year in emergency medicine, I was actually the department's research director, which is something that no one could conceive of today. But emergency medicine was so understaffed and under academic at that time that I was able to fill that role and assist not only my fellow residents, but also some of our attendings with doing some clinical research.
It's really interesting about your point about emergency medicine being a relatively young specialty, because it's always been bolted onto the College of Surgeons in the UK anyway.
Yeah.
And so it took a while for us to get our own status in our own college. So just feeding back on that point, which has happened in my lifetime as well. But do carry on.
Yeah. So I finished my emergency medicine residency. I became an attending at a large, very busy quaternary care county hospital in Arizona, which was the proverbial knife and gun club. Great trauma training setting. A lot of medically indigent patients who had very complex medical problems, very challenging and very satisfying place to work. I was there for a number of years, and then later moved to the University of Pennsylvania in Philadelphia, and became the first chair of the Pennsylvania Hospital, which many of your viewers and listeners may not know, but was the first hospital established in the United States. It actually is older than the United States. It was founded by Ben Franklin and Thomas Bond several years before the Declaration of Independence was signed. So a very prestigious and historical place, now again part of the University of Pennsylvania. And I was there for a number of years, continued my research career at a subsequent time. After 12 years, 13 years, I moved for a while to Thomas Jefferson University, where I was on the emergency medicine faculty, but was more involved in education and university administration, becoming an associate dean and associate provost, becoming more and more involved in non-clinical activities. And as often happens in academic medicine, began feeling a little less content with what I was doing. Wasn't really what I'd gone into medicine to do. My career path was interrupted in the spring of 2020, as were those of many of our colleagues, when I contracted COVID fairly early on in the disease. Was pretty sick, hospitalized for a couple of weeks with bilateral pneumonia. Took quite a while to recover. And during my longer than I'd wanted convalescence, I went back to some of the work I'd done with the pharmaceutical industry through the years, as a researcher, as a key opinion leader, as a consultant, and was able, while really not able to go back into clinical work, was able to amp up that work, and slowly became what I call, I think it's a made-up term, but a polyconsultant, where I worked with multiple companies and groups in different spaces, not even always with an emergency medicine or urgent care medicine focus, but most often with a cardiovascular focus. My research and my excitement from clinical practice in the emergency department came from cardiovascular emergencies, particularly thrombosis, DVT, PE, stroke, myocardial infarction, atrial fibrillation with thromboembolic stroke. And I was working in all of those spaces. And my wife and I decided that maybe it was time to have a little bit less hectic lifestyle and just continue this for a while and see if it would work out for us, both in terms of satisfaction and also in terms of earning a living wage. Having been employed by universities for nearly 40 years is a little scary to not be employed by anybody. But it worked out fairly well. And early on, one of the consulting opportunities I had was to become the consulting medical director for a CME company, with the very creative, I say that tongue-in-cheek, name of academic CME. And it's been a lot of fun to work with academic CME, because not only have I had the opportunity through that group, which does education in oncology, pulmonary medicine, dermatology, rheumatology, neurology, because I was part of the process of securing funding for educational programs and then talking to the thought leaders and doing that who became the faculty in those programs. It really greatly broadened my clinical perspective beyond what I had ever had or ever could have achieved in the emergency department. So that was a lot of fun as well. And the other thing that I was asked to do was to try to come up with some new and creative platforms for the delivery of continuing education. And I think academic CME has been successful in doing that. For example, one of the things that we sort of pioneered, and I think academic CME does better than really any other companies in this space, is the delivery of accredited education on what used to be Twitter. Now I guess it's properly called X. Although even on X, these programs are still referred to as tweetorials, which is it's actually very similar to a 20 or 30 minute lecture using slides. It's just that instead of the slides and the spoken voice, you have tweets and graphics. And that's been very rewarding and has captured a whole new audience of clinicians who like getting their education on demand and in small bites. So that's been another source of satisfaction for me. And I've been very fortunate, I think, Andrew, that I've been able to identify these different areas by working with companies that are developing novel drugs or trying to optimize the use of drugs that are already approved, and then having the opportunity to either directly or help educate my peers on how this might impact their practice and patient outcomes. And I've been able to satisfy my emergency medicine mindset, which I know from our earlier conversation that you share. We all, to succeed in this field, we have to have a touch of ADD. And so to have multiple balls in the air at the same time actually works very well for me. Hopefully it's going to keep my brain moving in an agile fashion, but that remains to be seen.
Amazing, very interesting origin story and journey through emergency medicine education, public health, academia. You actually just mentioned that, this whole thing about balancing lots of balls in the air.
Yeah.
I mean, medicine today often demands clinicians wear too many hats. How do you see that playing out across, mainstream medicine, academia, and CME in your world?
Well, for me, I've sort of seized control of the narrative, and I've been fortunate to do that. But again, I'm fairly senior. I have a lot of experience in these different spaces, so that's made it easier. I mean, I just was asked last week to chair a DSMB, a Drugs Safety Monitoring Board, for a big clinical trial, which is another view of how drugs are developed, how medicine advances, with attention to patient safety, which obviously is a very critical element these days, which lay people are, I think, more concerned about than ever before. The sort of paternalistic approach to medicine doesn't seem to fly much anymore. Patients will do their own research. They'll comparison shop. They'll come to you with ideas that they want you to consider. One of my least favorite experiences as a clinician in the emergency department is when a patient comes into the ED visit with 20 pages printed out from Google about their symptoms and what they think I should do about them. But on the other hand, patient empowerment, patient engagement is very important. So I think, again, there's no, at least in US medicine, there's no avoiding, even outside of academics, this need to wear multiple hats. Because the practice of medicine, the physical practice of medicine, and being compensated for practicing medicine and managing patient expectations is so much more complicated than it ever was before. I like to tell people I finished medical school right at the end of the Marcus Welby era, when physicians would still make house calls. And it's interesting that now, because patients demand it, we are seeing more and more physicians, whether they're concierge care physicians or hospitalists or externist, as they call themselves sometimes, again, making house calls because that's where they feel like they can impact patient care the most. I think even if one doesn't want to, one must wear a lot of hats in clinical medicine. If you add to that academic medicine, which of course involves not only administrative responsibilities, but teaching students, teaching residents, role modeling, taking the lead in sometimes in initiatives, quality initiatives that may not be one's cup of tea, but it has to be done to make sure that we're doing the best we can for our patients. Involvement in hospital committees like IRBs, and again, quality improvement, performance improvement committees. These things are sort of expected now. And I'm not sure we're doing a great job of preparing people for that in medical school. I guess it remains to be seen over the next few years. In the U.S., again, right now, there are some different sort of ideas percolating through organized medicine, coming from Washington down, that are not things that ordinarily those of us who trained 20, 30 years ago would embrace. But there's a cohort of patients out there that are embracing them. And we're going to have to deal with that and different expectations of physicians. So we're in addition to being clinicians, we're often in the role of being sounding boards and sort of managers for patients, which again, we don't necessarily have the training for, and often is very time consuming, and therefore can create frustration among clinicians who want to take best care of their patients, but because of the different demands they have on them, they may not have the time to do that.
Thank you. I guess you've seen over your career path the massive rise in credentialing and certifications and admin layers that are all put upon us as clinicians. Do you think that's really helping or hindering clinician wellness in your eyes?
Well, in emergency medicine, it's often referred to as the merit badge mentality. We have been in the past expected to take advanced pediatric life support and advanced cardiac life support, advanced trauma life support, and have all of these certificates and wallet cards that are current. We often are asked to do other training that the hospital mandates, to go back again to the HIV epidemic. We all had to do the training safety and the enhanced blood and body fluid precautions and personal protective gear and all that sort of stuff. It all carried a certification that had to be in your record in the medical staff office that you had all of these things. I think it's very easy to expect too many merit badges to be fulfilled, and for the standard to be expanded beyond where it needs to be. Some things obviously are very important. We have to demonstrate currency with important concepts, but the idea of taking a course or completing a certification for something that may not be often used or may not really contribute to one's either patient care approach or one's satisfaction with their career, I think can be harmful. But there's again this move to demonstrate competence and capability according to standardized testing and standardized courses that is sort of foisted upon us, and I'm not sure that it always has benefit.
Thank you. What about work-life balance? Where are we at with work-life balance in 2025 for clinicians? Is this more of a system design flaw, or is it a cultural expectation issue, do you think?
I think it's both. People from within and outside medicine will tell you that the internet is both the worst and the best thing that ever happened to them. The fact that you have Wi-Fi wherever you go, including at 35,000 feet flying over the ocean, means that it's hard to disconnect these days. It takes a conscious effort to disconnect. And no matter how much one loves one's career and one's work, there has to be a time when you can sort of, forgive the pejorative, but zone out, just relax a little bit. That fosters creativity and new ways of thinking about problems that maybe have vexed you in the past. And I think being disconnected from one's career occasionally and for limited periods of time, I think is very important. And I think we're often discouraged from doing that. On the personal side, the demands of sort of 24/7 access through email and text and other contacts, I think can't help but impinge on personal time. People who have families, spouses, and children and grandchildren, perhaps, with whom they want to spend time. I think find it harder than ever to quarantine that time away from work responsibility. It involves doing things that are sometimes antithetical to us, like turning cell phones off or leaving them behind for a couple of hours while going out for a hike where, part of you knows that there's good bandwidth out there in that hike. You could have your phone with you. And so it takes a conscious effort, I think, to try to maintain some sort of work-life balance. I don't think any of us are particularly good at it. And I think that I hope this doesn't sound bad. I think the better one is at work-life balance, the more guilt one may carry about having left something behind on one side or the other. Because I don't think there really is a safe balance. I think it has to be a very fungible and flexible thing that varies from day to day and requires a lot of self-discipline that many of us who are very driven in our careers have a hard time doing. That flexibility always seems to come at the expense of something else. And so we're constantly making value judgments and trying to decide which value is going to drive this decision. I think it can be very anxiety provoking and frankly, very difficult.
Yeah, agreed, especially with we're all conscientious people as clinicians. And so I take your point about having that guilt feeling about sort of taking all this on.
And frankly, you don't want a physician or a clinician who's not conscientious about what they're doing. And then again, your spouse doesn't want a spouse who's not conscientious about maintaining a relationship and putting in the work needed to do that. So I think we're all being pulled. And again, this is by no means limited to healthcare providers. I think we're all being pulled in many different directions these days that 15 to 20 years ago, none of us could have ever anticipated.
Thank you. So what are some of the structural bottlenecks that clinics are facing today, especially those who are trying to do it all, perhaps much like you have with your various things that you've been involved with during your career?
So I think forever, you go back to the beginning of my career or where I am now, the bottleneck is time. The bottleneck is time management and the ability, I think this is particularly difficult for many of us in academics, the ability to say no. When a colleague with whom you've done work in the past, or even if you haven't done work in the past, if you know that colleague is doing something meaningful and interesting and ask you to be involved. I think many of us have a very difficult time saying, no, thank you. And the problem is, of course, these things pile up on each other. And very soon we run out of time to do any of them particularly well. And while I do like the idea, we already had the metaphor of juggling. While I do like being involved in multiple things at the same time, I have to really try from a self-discipline standpoint to limit the number of projects on which I'm involved, no matter how much they appeal to me or how important I think they are, because I'm not doing myself or whoever's running the project a lot of good if I'm not fully dedicated to it. But in academics, we're not usually taught how to say no. I always admire people who do. I've had colleagues, close friends, in addition to professional colleagues, who I've asked to become involved with projects that I'm running in the past, and it's a bit of a blow when they say no. And I think we're all programmed. Clinicians, we're always taking histories. You can't help but ask why. And if the answer is, I just don't have enough bandwidth right now. I think that degree of honesty and that degree of self-reflection is very important, but I think it's hard to achieve because, Andrew, my response typically when someone says I have too much on my plate is for me to say, you need a bigger plate. At some point that takes a toll, whether it's on your physical health or your mental health or your relationships.
I hear you. So when you think about clinician burnout, because we've been sort of alluding to that as we've been talking, what part of the system needs to be fixed first, do you think?
Well, it's interesting because, over the past 20, 30 years, whenever you hear physician burnout, people say, oh, ER docs first. And it's because of the stress of the the unknown, and never knowing what's coming in the door next, and it could be something as mundane as a sore throat, or as life-threatening as a gunshot wound, or multiple trauma, or a stroke, or heart attack, or whatever. From a system standpoint, I think the only two things that can be done are, number one, to try to achieve, if you're running a system, to try to achieve for your providers a structure in which there's a little better balance between the delivery of care and all of the administrative efforts that have to go around that delivery, whether it's charting or billing, or committee participation at the hospital, or other activities that are clearly part of the job description of a clinician in practice or in a hospital, but don't bring the same level of satisfaction, and often have with them a time commitment that is just untenable. So I think for people who run healthcare systems to understand the stress and strain on physicians, whether they're emergency physicians or pediatricians or obstetricians or whatever, and recognize that the pressure and the stress that come from taking care of patients is very different from the stress and the pressure of completing paperwork. Now, completing paperwork is a necessity for getting compensated, and getting compensated is a necessity for keeping one's practice or keeping one's hospital open. So it all has to be done. But I think a better recognition of the effort required is important. And in emergency medicine, a lot of times we're addressing that now with, for example, voice-to-text documentation, or I think something that's been very effective for the emergency department is having scribes, who often are medical students or paramedics, or people with a little bit of clinical knowledge, who are attentive and who can distill, almost like a court reporter, distill the communication back and forth between the patient and the provider in real time, so that later then the clinician can just read over those notes and edit them, as opposed to having to generate them de novo, which of course takes more time and effort, and under time constraints is stressful. The other thing that we need to do, besides appreciating and trying to compensate for the pressure of different responsibilities, is I think we need to, and this is hard for me to say, I suspect it's hard for you as well, we need to be more respectful of the need for clinicians to share their burdens. In a typical ED shift, you or I will see 40 patients, maybe more if we're proctoring residents and fellows. And our job is to hear those patients' complaints, try to synthesize an explanation for those complaints, and then with often very limited information, craft a plan for what to do moving forward. That is stressful. And you multiply that over a 12-hour shift by 20 or 30 or 40. And always with the nagging sense that, have I missed something? Or have I taken the resident's history too literally? Are there questions I should ask on top of that? And in the meantime, you hear buzzers and beepers going off telling you you've got other patients to see. I talked earlier about having some time to disconnect. I think many of us, though we may be loath to admit it, many of us may need some help in zoning out and addressing these issues. And the only way that's going to happen is if we start to remove, or at least attenuate, the stigma that many healthcare providers feel about asking for help. We're the ones who help. We're not the ones who look for help. And I think the sooner in one's career one realizes that that's not a stigma, that's not a negative, that it's not a sign of weakness, I think we'll all be more healthy people, and therefore be able to be more healthy providers. That's within a system where when I did my internship on surgery, and we were told we'd be on call. This was before all the current resident work hours that are in effect now. We were told we'd be on call every other night for those 2 months. And I remember the chief resident saying to me, you know what the real problem is with being on call every other night? And I thought, okay, I'm not sure how I should answer this because he's a surgeon. So, I mean, he's going to be real gung-ho about this. He said, before I had a chance to craft an answer that might or might not have worked, he said, it means you miss half the good cases. So that's, when that's the mindset, it's very difficult to carve out space for yourself to reflect and recover. It need not be a prolonged time. Sometimes 5 minutes of quiet meditation is enough to just sort of reset. But I think often we're conditioned, again, particularly in emergency medicine, that there's no need for that. There's no time for that. Get out there and see the next patient. You got to, in the expressions we use, you got to move the meat because there are hospital administrators and insurers and the public in the U.S. publicly reported metrics who are watching what the wait time is in your emergency department waiting room or what the throughput time is. Or how long it takes you to get a CT scan result back. And then the question, if it's really long, the question becomes, well, did you really need that CT scan? Because you ordered that, you kept the patient around for an extra 3 hours. The 3 hour wait for the scan and the interpretation may not be your fault, doctor, but you did order it. Did you really need it in retrospect? When everything's being questioned and the pressure is there, it's really important that one have some escape valve that's hopefully not associated with alcohol or illicit drugs to just reset from time to time. And I think that's challenging for many of us.
So it's all about self-care and looking after each other. And I was nodding and smiling there because this all resonates. I'm still working in an emergency department, and all the things that you just mentioned about the pressures are so true and reflect everything you've just said. So if you were mentoring a younger clinician or educator today, what would you advise them to do perhaps differently from what you did?
Well, to be honest, the system has changed. And a lot of the things that I've done wouldn't necessarily be feasible right now for someone just coming out of training. Again, the residency work hour requirements have changed. The intrusion, and I don't mean that by any means to be all negative because some of it's very positive, but the intrusion of technology into practice has changed the way we do things. The diagnostic testing that's available to us now, it can very much shorten or streamline the path to a diagnosis, but at the same time, it can create more questions. And so the ability to, as I was able to do, particularly early in my career, to sort of sequester my clinical time. And I was always in an academic environment, so I always had protected time for other things. But my clinical time for the other things I wanted to do, research, teaching, other activities that, working with patient support groups, that sort of thing, working on an IRB and reviewing research protocols. A lot of times now there's just not time to do all of those things. And so while I was able to do many of those concurrently, what I do tell someone coming out of training now is to work very diligently to identify one or two passions beyond whatever you're doing. If you're, surgery, if you're a surgeon, delivering babies, if you're an obstetrician, plotting out chemotherapeutic regimens, if you're an oncologist. I mean, that's you don't want to. If you pick the right career path, you don't want to escape from that. So you've got to do that. But I think it's really important, instead of thinking that the other parts of your career and the personal satisfaction you get from that career are like a buffet table or a smorgasbord, and you can take a little here and take a little there. I think if you do that, you're destined to be disappointed in either what you can accomplish, frustrated by the lack of time to do multiple things, and then ultimately disappointed in yourself, which is not positive. So what I would say is, particularly early in your career, when you're trying to establish yourself in practice and establish your own practice routines, don't try to take on too much else. If there's one or two things that really get you excited, whether that's research or teaching, whatever, by all means, try to pursue that in the time you have available to you. But don't try to do a little bit of everything, because you'll end up, number one, not doing any of those elements well. And number two, it'll probably boil over into your primary role, which is as a clinician, and damage either the amount of time you have to put into that or the amount of satisfaction you get from it. So I think the key piece of advice would be to find a passion and then ration your time appropriately. And of course, that's just on the career side. There's the whole issue of personal life as well. And I can tell you, no matter how satisfying your scientific or clinical career may be, if you're not finding happiness at home, whatever home looks like for you, it's just not going to work out. It's not sustainable.
Thank you. So finally, what over the next year, what's something you're particularly excited about, whether it's a project at academic CME or education or broader reform?
I think maybe what's most exciting is trying to couple medical education that we do for physicians and nurses and pharmacists and NPs and PAs with patient education. Right now, I think those two are completely disconnected. We have established systems of medical education, some of which are changing now. They're schools that are trying to go from a 4-year curriculum to a 3-year curriculum, or changing residencies from 3 years to 4 years. But basically they're just modifying around the edges. There are no real huge changes in how we train clinicians. I think not in the next year, but going forward, we need to reevaluate those more critically. And in this time of greatly enhanced technology compared to when the Flexner report was published, 120 years ago, and residency review committees were set up 100 years ago or 60 years ago, whenever it was. We've got to change the institutional training of clinicians. But once they're out, once they've completed that, they have whatever that degree is, whether it's a PharmD or an MD or an RN or an MSN. There is a need for continuing education. And that has to be done in a way that is consistent with the pace of medical advancement and with what patients expect from the system. At the same time, patients have a right to expect more than they ever did before because patients are aware of the advancements in technology and drug development. And yet, for the most part, because clinicians are so pressured in their practices to have so little time to talk to their patients beyond, collecting an immediate history, making an immediate decision, and then moving on to the next step. What patients are left with, at least in the U.S., is something that I think is not particularly helpful, and that's so-called DTC education. So direct-to-consumer education, what it really is direct-to-consumer promotion. So in the U.S., you can't turn on the television, whether it's to watch a sporting event or a cultural event or a movie, without multiple interruptions about drugs that are, in the U.S. by definition approved by the FDA. So they're approved drugs, and of course, what they can say about those drugs is limited to what's in the label. But these are promotional nonetheless. And I think it's information overload for patients, particularly towards the end of the commercial when they always start talking really fast about the side effects you have to be alert to. And I think they can set up false hopes for patients, perhaps even about a diagnosis they don't even have. There are lots of migraine commercials these days. There are patients who view those, who come in to ask about those therapies when in fact they don't have migraine. They have another source of headache, even if it's a different type of vascular headache. Those migraine meds that they're seeing advertised don't necessarily help for cluster headaches, which may be what they have. So I think if we can prepare clinicians to address patient questions and needs about their diagnosis and their care, outside of the context of the type of promotional information they're receiving on their own when they're not talking to us, I think that's a very important disconnect that we can try to reconnect. And I think technology will help us there. If you can have a continuing medical education program presented on X, and you can have a patient education program presented by a trained educator clinician presented on TikTok or Facebook or someplace or Instagram where the patient is, and deliver sort of a unified message at the appropriate level of medical literacy, then I think we can really advance care. And I think we may be primed right now to, for the first time, consciously and deliberately, and I hope successfully, couple ongoing medical education with commensurate patient education so that expectations can be more readily met and patients feel more empowered to be more active participants in their own healthcare. So maybe a year is too optimistic a time frame for that, but I think we need to head in that direction. And this is one of those areas where clearly we can harness technology to help us get there faster than we could have in the past.
Great. Charles, this has been so insightful. Thank you so much for sharing your experience and thoughts on these different matters. I know our listeners will resonate with your perspective, especially the layered reality of balancing patient care, education, and academic responsibilities. Thank you so much for your time. Really appreciate it.
It's been my pleasure. Thanks for the opportunity.